Good morning, everyone. My name is Ann Mon Johnson, and I am CEO of the American Telemedicine Association. The ATA is the only organization focused exclusively on ensuring that telehealth is broadly available to people across the country to ensure that all Americans get care where and when they need it, and that when they do, they know it's safe, effective, and appropriate, while enabling clinicians to do more good for more people. Our members include delivery systems, it includes the VA, payers, and a range of solution providers, the traditional synchronous video providers, as well as asynchronous providers, and then a host of organizations that are enabling telehealth either through technology or remote monitoring and the like. So it's really a broad and eclectic community. And we have been really active, as you can imagine, for the last 3.5 years. But now we have this opportunity in this fantastic conference and with this audience, and thank you again to Heather and to HRSA for making this possible, to focus on, going beyond the pandemic and going into really where we're headed next in terms of underserved communities. So with that, I have a great panel joining me, and I would really like them to introduce themselves, starting with Renee Quashie.
Thanks, Ann. Renee Quashie, I'm the Vice President for Digital Health at the Consumer Technology Association. We are a large trade association representing the tech industry. We have about 1,200 or so member organizations across the technology sector. You name a technology category and we have members in it. Obviously, I represent the health facet of the association. It's the fastest growing segment of our membership at CTA. We have a very strong health division that is really representative of the ecosystem. We have telemedicine companies. We have what I would call traditional tech companies with healthcare interests. We have digital therapeutics companies, remote patient monitoring companies. We even have a large health plan. And so we really do span the entire ecosystem. We're probably best known for CES, which is our annual trade and business event in Las Vegas, Nevada, that occurs every year, where we bring the tech community from around the world to one place for 4 days of meetings and networking and conference programming. The last thing I'll mention is we are an ANSI accredited organization. There's probably almost no piece of consumer technology that has not been touched by a CTA standard. We always like to cite airplane mode on your phone and closed captioning as sort of the standards that you would be most familiar with. But on the healthcare side, we have published 26 industry standards on everything from artificial intelligence, to digital therapeutics, to mobile health. We also have a working group that's working on developing a telehealth standard. I'll finish by saying I'm a lawyer by training. I practiced law for over 20 years at various law firms in Washington, D.C.
Great. Thank you, Renee. Amanda.
Hi, good morning, everybody. That's a tough act to follow, Renee. You've got a long history there. Really grateful to be on the panel with you and with Ann. I am fortunate to wear 2 hats as the Executive Director of the Association of Clinicians for the Underserved and as the CEO of Advocates for Community Health. Both organizations serve primarily fairly qualified health centers, but on the ACU, the Clinicians for the Underserved side, we're really working and supporting any clinician and the healthcare workforce as a whole, and organizations really across the board that are serving underserved communities. ACU is in its 27th year. We're just about in our 28th year. We were founded by members and alumni of the National Health Service Corps who came together and really felt that the needs of this population were a bit different. And for that matter, and that reason, the clinicians in the healthcare workforce serving them also needed specific services and supports. And so from that grew ACU. We spend a great deal of our time working on workforce issues, but as a national membership organization, of course, we're trying to meet the needs of our members across the board. We do a great deal of policy and advocacy work, Of course, telehealth has been central to that, particularly as we came through the pandemic and are continuing to work our way. But in light of the fact that the patients that we're serving, of course, have a huge need and the importance of telehealth as it relates to access. On the Advocates for Community Health side, we just finished our second year toward the end of July, which is wild. We're relatively new, but we also serve FQHCs, primarily larger FQHCs. So there's a specific criteria for that, but these are some of the largest health centers in the country. And they too, a lot of them are innovating because of their scope and their size. They're in a position to be able to innovate in ways, as many of their colleagues do, even the smaller organizations, but to make sure that they're meeting the needs of their patients. And again, I think telehealth has played an enormously important role in that, again, coming through the pandemic and just in consideration to access issues, rural health, and so forth. So really looking forward to the conversation today. Very grateful to HRSA for putting this together. And I will turn it back to you, Anne.
Thank you. And finally, not last but not least, Alan Morgan.
And thank you so much. And I'm delighted to join such a distinguished panel today to talk about a topic near and dear to my heart, and that is telehealth and telehealth policy. I'm the Chief Executive Officer of the National Rural Health Association. We're a membership organization. If you care about rural health, there's a home for you within our group. More than 22,000 members across the U.S. And this includes both providers, patients, researchers, policy leaders engaged in rural health policy. Most notably, more than 90% of the nation's rural hospitals, rural health clinics, and rural community health centers are members of the National Rural Health Association. We do education, we do networking, we do policy, but what we're really engaged in is identifying best practices, sharing those best practices for hope of replication. And from time to time, we see policy barriers to implementing best practices, and that's where we engage in advocacy and policy development as an organization. It's important to note that rural is not a small version of urban. It's a unique healthcare delivery environment where those patients most often in need of healthcare services oftentimes have the fewest options available to seek that care. Workforce shortages, vulnerable populations, all these play into account when we talk about the role and the necessity for telehealth access and availability among rural communities. So, Anne, let's tip this thing off.
Perfect. That's great. And before I do want to go through a couple of housekeeping items. First of all, we will take questions from the audience, and you should put those in the Q&A function. The chat function is disabled, so Q&A function. You can also switch on closed captions within Zoom if that's your preference. And sign language interpretation is also available and can be switched on within Zoom. So again, most importantly, we will have time for questions from the audience, and so please put them in the Q&A. But it's my opportunity to kick it off with the first one, which is one thing that we learned in the past 3.5 years, and I think we've all have our stories to tell on this, is the range of use cases for telehealth or for digitally enabled care or technology enabled care. How are your organizations, each of yours, supporting the integration of telehealth as a modality of care available to providers and patients when an in-person visit is not necessary or not possible? So let's start with you, Amanda.
Gladly. So it's quite diverse as it relates to FQHCs, but I think one of the ways that we've seen, and it's been most important most recently, is that it's given us an opportunity to connect patients to specialists and other providers that are not necessarily on site at the health center. It's a really important way to connect, particularly in this time of severe workforce shortages that health centers are facing as others, to connect folks to those providers without disruption to care. I think one of the other more important uses that we've seen at telehealth serve as a resource is for patients who serve that are unable to travel to get to their health centers within normal hours. And that, when you think of our patient population, 90% are at or below 200% of federal poverty. Mm-hmm. So many of them are working multiple jobs. Many of them have limited access to transportation. There's a whole number of social drivers that prevent them necessarily from being able to get physically to an appointment. And the opportunity to leverage telehealth as a modality of care has dramatically changed our ability to create continuous access for those patients. So there are a couple of examples, but I'm sure Renee and Alan will have much more to expand on.
Go ahead, Alan, please.
Yeah, well, let me build a little bit off of what Amanda said. I think from a rural standpoint, the access to specialty care has kind of been a hallmark of telehealth services in rural communities. I'm excited to see the expansion of telepharmacy, telebehavioral health, and even teledentistry that we saw during COVID. Finally, the realization of expanded access to care in some of these communities. And again, the opportunity in many cases of having some of the state's top specialists now be able to be there present with rural patients in their own community. I think it's huge. Going ahead, you just can't understate the importance of telehealth when it comes to behavioral health and mental health services in a rural context.
Renee, what would you add?
The one thing I'll add is that a lot of our members have really been focused on how health technology can advance health equity. So during the pandemic, we formed the Health Equity and Access Leadership Coalition, or the HEAL Coalition, in partnership with the Connected Health Initiative, to really analyze ways in which this can be done. We had about 35 member organizations and others who came together to sort of think through a lot of these issues. It was an incredibly diverse group from insurers, providers, health systems, technology companies, investors. We had some government representatives on it. And so we've really been sort of focused on that, because I think if you were to ask most of our members, I think they would say, look, there are so many ways in which digital health, including telehealth, can advance health equity, right? Close communication gaps, for example, between patients and providers, increase accessibility for people with disabilities and older adults. And we could get to sort of some of the misunderstandings about older adults and their comfort with technology, increase consumer access to healthcare providers and services, increase consumer access to health information, just information generally. We think that digital health can increase patient engagement in understanding and managing health. And I think Alan talked about this before, sort of improving providers and consumer ability to segment populations and tailor particular services, particularly when it comes to subspecialties. So that's one area of focus that we've had over the last 3 years, and it continues.
You know, it's interesting. We likewise at the ATA had formed an advisory group on using telehealth to eliminate disparities. And like yours, it was an amazing group of individuals who contributed their time and insights and experiences. The first product that the group released was a framework for how telehealth could be used to eliminate disparities, and looked at different components. And it was conveyed as a triangle or a pyramid, and the top of the pyramid was connectivity. And we were very deliberate about that, because the idea was that with connectivity doesn't mean you're going to solve for everything else. So if we have broadband across the United States and everybody's wired or has their own personal space link, it doesn't solve for the problems. And beyond that, there's the affordability of the data plans, affordability of the devices to access the services. There's issues of health and digital literacy that we have to contend with. And then another really fundamental issue that I think we're all starting to see more and more in our work is the issue of trust. There are literally decades of mistrust in the healthcare system that are associated with underserved communities in particular, but unfortunately it's increasing as well. And so we have to address that. And I think that, again, technology and technology-enabled services are going to be a great boon to making that happen.
Yeah,
Let's go on. Yeah,
I was just going to add that. Yeah, I was just going to add to that I think one of the things that our group concluded was, and I think this is obvious, but sometimes it isn't, is that a lot of the issues we discuss when we're talking about health equity cannot be analyzed in a vacuum, right? There are broader equity issues, not only in healthcare, but outside of healthcare in general American society that play a huge role and are reflected in some of the health disparities we see.
Absolutely. Amanda, Alan, anything else you want to add?
I would just, so everything that you just said, and I would echo. I think it's interesting. I was just having a conversation with a partner yesterday about digital literacy in particular, particularly as we see the elderly populations that are, kind of trying to find their way and navigate in this space. And then you add into that, challenges with dementia and other, again, social drivers, but the need specifically to invest more and create resources to support that part and that segment of the population, which is growing, quite frankly. So, but no, I echo everything that you just mentioned. And, it's not, we are very carefully watching and doing a lot of policy and advocacy work to ensure that some of the shifts that we've seen in the last couple of years can stay intact, because they are so critically important to staying in place, especially for our population and for the providers. But Alan may have more that he wants to add as well.
Yeah, absolutely. It only took us 15 minutes to hit into the policy advocacy component of this. I'm in our Washington D.C. office today doing exactly that. And the context is, how do we extend the flexibility that we've had for the last few years to a permanent status going ahead? I think there's always been the long-standing concern of runaway costs. We just haven't seen that. If anything, we haven't seen the uptick in rural communities that we want to, certainly when it comes to primary care delivery and utilization of telehealth as we move forward. So I think that's job one going ahead, is making sure that we can accurately make the case of what this does to improve healthcare access and quality in rural communities, and the necessity of having this flexibility as we move forward.
Completely agree. And I would just conclude this one question with a guiding principle of our work. We have several policy principles that inform the work at the ATA, is that telehealth or technology-enabled care should not be evaluated or judged by different standards than in person. So it's simply a modality of care that should be made available to the clinician and the consumer, the provider, the patient, when appropriate. And again, this whole idea of not holding it to a different standard is something that we spend a lot of time on. Let's move on then, if we can. We've seen many benefits from telehealth, including increased access to care, which you've all touched on. What have your stakeholders identified as the biggest benefit from telehealth and the reason they want to continue using telehealth? And at the same time, where do we need to redouble efforts? What communities or areas are still not benefiting to the extent that they should? Alan, let me start with you, please.
Thanks. I appreciate that. Yeah, I think looking at the experience in the last 3 years, from a rural context, there may be a rural hospital that's not doing teleradiology. I'm not personally aware of that. So in that context, telehealth has been operational in a rural context for many years. But what we see now is what the realization of a clinician in a rural health clinic or a rural community health center actually being able to see that homebound senior in their rural community in a primary care visit. Now, that's not always the case because of broadband issues, but that really is a game changer, I think, for us to be able to meet rural patients where they need to be going ahead. Now, what we haven't seen yet, and one thing I'm hopeful that as we move forward, is the utilization of telehealth in public health. Public health in a rural context has been underfunded and under siege for the last 3 years, and we're just never going to get the boots on the ground that we need in these rural communities. So I think there's a lot of room for expansion and creative new uses for telehealth as we move forward.
Got it. Renee?
Yeah, we did a pretty extensive and comprehensive research project that we published, results of which we published in February. And what we found, I'm sure Ann, your organization has found very similar, is that the vast majority of consumers have used telehealth, and that there's an incredibly high satisfaction rate. From our survey, it was over 80%, which is incredible, right? And, we further asked some questions in our study about why this is, and some of it is about less waste of time at a doctor's office. We all know not only how inconvenient it is, but how disruptive to our lives it is to just go for a primary care visit. The other thing we found that was interesting in our research is that providers are starting to like this. Before, we had always focused on the consumer and whether the consumer liked telehealth, but we always sort of ignored how the clinicians felt about providing services this way. And again, our survey found that 60% of healthcare providers really like using it and believe that telehealth and digital health more broadly is a great means to alleviate a lot of the burdens on the healthcare system. There are some issues though, and I think even though COVID-19 was a game changer, and we can talk about this a little later, seems like we may be slipping back a little bit into our pre-COVID attitudes. And that's going to need to be addressed. The other thing we found is that reimbursement, coverage and reimbursement, not just at the Medicare level, but also at the commercial payer level, sometimes interferes with people's abilities to want to use this particular way of care. So we really need to look at that. And then the last piece I'll mention is, we can get to this more later, is you talked about trust. And I think from a lot of discussions we have with payers, others, there's also seems to be a lack of trust in the evidence, the supporting clinical evidence about some of these technology-enabled solutions. And so that has to be overcome. Some of that is myth, and some of that is fact. And I think a lot of people have trouble separating the two.
I would completely agree. Amanda, did you want to add something?
Yeah, I'll call out a couple of things. I think Alan and I are very much, on Renee too, but I think Alan and I probably have a really similar lens on this. So I'll just build on a couple of things that he mentioned. So I think that behavioral health is an area where we have seen massive importance as it relates to this specifically, and it has to do with a couple of different things. Of course, there's a workforce shortage in the space of that particular provider type, and so just by virtue of the fact that you don't have enough providers to be able to get to the number of people in need, then you layer into that access in rural areas and other barriers that exist. And so being able to provide those services via telehealth has been so critically important and such a massive benefit to our patients. I also think, and it doesn't just limit to behavioral health, but I also think that the stigma attached to accessing those services, telehealth has also been really beneficial as it relates to that. And so I think, again, if I'm looking at how do we continue to build and expand on what we've learned and seen by necessity over the past 3 years, but, again, lesson learned, this is something that's working very well. And we have documentation of that. Patients have responded. But I think the other thing is, and this builds a little bit off of what Renee mentioned, from a provider perspective, it's very interesting, at least in the health center space, in that about half of the providers out there really appreciate the balance of in-person and telehealth, and the other half prefer one to the other. And so from an operational perspective, and again, kind of going back to workforce, how do you recruit and retain, particularly in areas of underserved, communities and populations, this has become a really important tool for health centers, especially, at least in our case, in order to retain clinicians. And then the final piece that I'd say is that, and I think this has come up a bit in the Q&A, there's a lot of different segments of both providers, but I think healthcare workforce as a whole, who have just done wonders to create efficiencies across operations, to create greater access to care. I'll just share one story, and it speaks to maybe something that Renee was getting at in terms of efficacy and data. But, I was speaking with a health center sometime last year about this, but they had a patient who was a, frequent no-show for a variety of reasons for years and had chronic conditions. And so obviously when you're not showing up for appointments, you've got chronic conditions, things get worse. And then through the pandemic, basically they were able to connect with the patient and discovered at that point that they were struggling with some domestic abuse, and that was actually the barrier to them coming in and accessing care. And in a matter of one visit, They were able to turn around her chronic health condition. They were able to provide and connect her with supports to make sure that they were able to get her out of that situation. And it transformed her entire health status, but also her entire ability to manage her health. So, there are so many of those stories where, yes, they're anecdotal, but I think if you take them cumulatively, the outcomes are there. And I think that that's all over the place. It's not just with health centers. I'm sure Alan has many of those stories as well, and probably Renee and you, Anne. But I think these are the things that we've definitely witnessed over the past few years that absolutely, verify and justify, from my perspective, the need to keep it intact, but to continue to build on those lessons that we've learned.
Quite frankly.
Go ahead,
Okay.
Renee. Sorry.
Yeah, I was going to say, quite frankly, we may not have a choice. Amanda, you talked a little bit about the workforce piece vis-a-vis behavioral health, but I think we see that across the board, right? I was reading a report the other day, and I was struck by the fact that according to the report, 60% of cardiologists in this country are 55 and over. Now, just think about that for a second, right? And so the question then becomes, I think we've got two parallel trends that I think are going to meet at some point. We got the workforce issues, we got the burnout issue, which everybody's talked about. I know the American Academy of Medical Colleges projects that we may be short up to 125,000 physicians by the mid-2030s. I saw a report on nursing, and we lost 100,000 registered nurses between 2020 and 2021, which is the largest drop we've seen in 4 decades. And we can go on and on and on about the workforce issue. So that's one trend. Then we've got another trend in which we're an aging population. This is happening in a lot of industrialized countries. And we don't need to talk about what happens to people's health as they grow older. But at the moment, I think 1 out of every 7 Americans is 65 and over. That's going to be 1 out of every 5 by the end of the decade. By the middle 2030s, we're going to have more Americans 65 and over than 18 and under for the first time in American history. We have the oldest median age we've ever had in this country. And so we have an aging population. We've got workforce shortages. And so I don't quite understand how we think we're going to solve the problem without really leveraging technology-enabled care. So some of this may be moot because we may not have a choice if we're going to meet demand.
Completely agree. And one of the expressions about digitally enabled or telehealth services is the idea that you're meeting people where they are. And our country in particular is very rooted in bricks and mortar. I say we have an edifice complex, and this notion of having people come to us for services, that's really getting turned on its head very much. And so when you think about underserved communities and meeting them where they are, I'm sure you all have stories or observations about parts of the community that are just trusted. So go back to churches, schools, and others, the idea that we might be able to reach people differently, use different resources that are more trusted than historically untrusted institutions. There is a question from the audience that dovetails into this, which is, and maybe it's tied most to you, Amanda, which is with the lower rates of telehealth use by minorities, the access to use services may not be the reason for the decreased use versus a lack of trust in the services and or processes. Will registered nurses, the most trusted profession, have the ability to connect and be able to create community clinics in their communities?
It's a great question, and it's very valid. I think that there still exists so much mistrust, I think, across technology and a lot of other spaces in healthcare. And I do think that nurses, as do several other clinicians, play an important role in helping to develop that trust. And I would also call out, I think, something that came up from Renee may have brought this up, but I'm sure Alan could speak to this as well. It's identifying people in the community to help and bringing those voices in very intentionally and creating that stakeholder group, creating the space at the table and being very intentional around, okay, how do we do this better? Where does the mistrust come from? And what do we need to do to address it? How do we create that buy-in? But that takes time. In terms of the ability to create community clinics that are nurse-driven and based, I think certainly on the ACU side, we're supportive of any, organization and any group of providers that are in a position to serve underserved communities. I think it depends on the format. And right now I will, I'm not the only one, I'm sure, that will speak to this from a policy and advocacy perspective. We are very much in crisis mode in terms of where we are with funding for the health center program and for some other critically important programs that sort of fit together. So teaching health centers, the National Health Service Corps. So when I hear about, and when, understanding the desire to set up some of these new organizations and new operations, there's absolutely the appetite and the support. Some of it does come down to federal resources and sanctions to be able to do it. And so we're advocating daily to make sure that that comes through. But I can't speak to the specifics of whether or not there's going to be an initiative specifically to drive that. Alan and Renee may have more to add on that part, but that's the best I can offer at this moment.
Yeah, I'd like to build on that if I could. And since 2010, we've had 156 rural hospitals close. We've had 15 rural hospitals close this year alone. And I think, unfortunately, at a national level, people assume that the reason why these hospitals are closing is because of low volume or bad management in these rural communities. The data just doesn't support this. And to the question, and to directly what Amanda was talking about, Shep Center, University of North Carolina research has highlighted that the majority of these rural hospitals have closed in communities with high African-American populations, high Latino, high Hispanic. This isn't a volume issue. This is an equity issue. And I think there's a strong case to be made of ensuring access by utilizing telehealth as a tool to expand upon that access. It's a great tool and resources to keep those hospital doors open as well, too. And so they're very much part of the reason why our organization launched this year the Faces of Rural campaign, to try to dispel the myth of what rural communities and rural populations are and the diversity among these underserved geographic areas that in many cases have tremendous diversity among the patients, at the same time, huge health needs, and they're facing in many cases a lack of access to care. So it just makes such a strong case for telehealth going ahead.
Got it.
I think, sorry, and just one other thing to add to that. Well, when we think about this population and we think of minoritized populations, and I just want to pause and build on what Alan just said about the equity issue, because the social drivers can't be, and not that they're being ignored, but they can't be excluded from the bigger discussion, And so when we talk about, yes, it's connectivity, but it's also, and this came up already, it's also the cost of data. It's having, we've got patients who are sitting outside of McDonald's to do their homework, let alone, access their care. And so again, when Alan speaks to the populations that are most affected by this, and I think the question getting at minoritized populations in particular, communities in particular, all of these pieces fit together. And so again, bringing it back to a policy and advocacy, what's the solution there? I think it has to be an intervention that takes all of those things into account, with the overarching intention of standing up more locations and more, clinics and health centers and rural health centers and rural hospitals, you name it, to make sure that people have that continued access. But I wanted to make sure that, the equity part of this is really important. And I also think that it's being really intentional about bringing those folks to the conversation to help drive what the solutions can look like.
Yeah, you can't do to people. You have to do with people. It's a very different mindset. We've talked about some of the challenges. We've touched on a lot of them. What do you see as the single biggest challenge or impediment to implementing telehealth, and why? Renee, you go first.
Yeah, I think
just one.
Okay. Well, if I have to do just one, I think coverage and reimbursement policy, right?
Okay.
We've been talking about this ad nauseam. You've been at it for a long time, Anne. How long have we been having the same exact conversation? You would think that COVID would have changed a lot of minds. I think it has, but it's still, from a Medicare perspective, a lot of the flexibilities we saw during COVID are not permanent, right? They're going to run out at the end of next year. And so I think coverage and reimbursement, both from the public payer perspective, Medicare, Medicaid, I think Medicare Advantage is a little bit different. So there's more flexibility built in there. But I think also on the commercial payer side, And I think this goes back to something I mentioned earlier about the evidence base. I do think there is a very strong evidence base, but I think a lot of folks choose to ignore it. I think there are some folks who are just not quite sold on providing care in this manner. So I think coverage and reimbursement are huge issues, but I think you said only one. So I'll come back to my other point later, because I think there are a lot of developments outside of the telehealth context and digital health that have tremendous potential to be game changers. But if we don't get the telehealth piece right, the other solutions don't have a chance from a coverage and reimbursement perspective.
Got it. Amanda, biggest challenge and why? One biggest challenge.
I know it's so hard when you limit it to one because there's a few. So I'll start by just like, yes, everything that Renee said 10 times over. That's a number one. But I also think patient access to technology. And I think that's, as I said, broadband, but it's also data capacity. And, I think there are other components when we talk about access to technology that could be remote patient monitoring. There's just a lot that goes into that. In terms of what we're doing, this is a big part of both for ACU and for ACH. This is a big part of our policy and advocacy work. And so we're trying to secure as much funds and resources as we can. And I think it's the continuation of some of the policies that are in place due to expire in 2024 to just make sure that, we don't go backwards.
Got it. Alan, one.
Only one. I was told there'd be no difficult questions today, so I'm a little concerned about that. If I had to choose one, I will choose broadband. And I will say that only because that is the primary barrier of that realization of a clinician primary care into a homebound rural household. And I think that is job one. And that being said, this is obviously, I think, the most difficult question you could ask today, Anne. So.
Got it. Well, I will just add, and I'll stick to one also, and it's a little out there, but I think the user experience in digitally enabled or technology enabled care is not terrific in many instances. And so that makes it hard for people to use. It makes it hard if they don't understand how to use tools and devices. And so I think, if we want to bring things to people, meet people where they are, let's take a page from the playbook of Amazon and the other great retailers out there and make it easy for people. So Adam Pellegrini famously said once upon a time, if you want someone to do something, don't make them do it. So that's something for us all to live by, I think, as we create new experiences. So let's go on if we could. There have been some recent studies, and Renee, you alluded to this as well, that note a preference by some clinicians and citizens to return to in-person care. For those of us, the four of us here, particularly focused on reaching underserved communities, what is your response to these studies? So who would like to take that first?
I can start. I think we may all have similar but a little bit different perspectives. Well, I think it starts with what you actually just said, Anne, which is that health centers are trying to meet patients where they are. And so for us, it is about basically it is preference, but I think it is that flexibility. And I think it's the same things with providers. And so when I hear those studies, it surprises me and it feels very dismissive of the realities of underserved populations in particular, because it doesn't line up with the experience in serving those communities and those populations. And I think, again, you heard me mention earlier that, at least from a workforce perspective, it's pretty split. I think that our providers too really appreciate the opportunity to do both, where, maybe they're seeing patients in person 3 days a week and they're doing telehealth 2 days a week, or vice versa. It really just depends on that provider's preference, but that's also based on the needs of the patients, and what we've learned operationally and in terms of efficiencies throughout the process of COVID and since then. So I think it's vital that we continue to reach the highest number of patients and improve their health outcomes. And I think for us and for our patient population, in person isn't always the answer. And so I think it's a misnomer to assume that that's, across the board. I also think it goes back to the equity conversation of, are those surveys taking into account the realities of the patients that we're seeing and the barriers that they have to access the care and services?
And I think the answer to that is no. What a wonderful problem to have, right? I mean, I cannot believe, I think of some of our underserved rural communities, and to have them say, well, I'd rather see a physician. Well, of course, but that's not an option. So I think it goes back again, and how you open this. Telehealth is a tool. It's not the end all be all for healthcare access. And for many rural communities out there, the telehealth will be the difference between seeing a provider or not seeing a provider. And I think it's a safety net tool, if nothing else on there. So I love this question. I hope it's a dilemma that every rural community has to face, but knowing the workforce shortages that we do face, this is a great problem to have.
I would just add that I think we overrate the in-person experience. I'll be perfectly honest. We've all been to a primary care physician. I don't know what other people's experiences have been, but I will tell you mine have not been what I would call rich in communication, right? You sit there, you're in the waiting room, you go into the office, doctor or clinician comes in. It's a very short conversation. Obviously, there are going to be times when being in person is necessary. I think we all agree with that. But take your average primary care visit. Is in person really that superior? I think we need to actually ask ourselves that question, because we always hold the in-person visit as the holy grail. But let's look at our own experiences, and we realize there's a lot lacking when we go in person to a physician. It's just not a rich communication experience. Now, I've availed myself of telehealth for the last 10 years, and I can tell you from my experience, I find the communication much richer in a telemedicine experience, because that clinician seems to be paying much more attention to what I'm saying. It's an actual dialogue. There are various logistical reasons for this, obviously. So I think we need to sort of look at the average in-person experience and note that it's not phenomenal. With the understanding that I think obviously in-person visits are going to be necessary for certain conditions and certain patients.
Hey, and one thing that I would add to this too, and it came up a little earlier in one of the other questions, but the reality, at least a lot of the cases that we see, telehealth serves as an opportunity to connect people with specialists. So, I mean, I think if you just look at the reality for some of these patients who have, needs that go beyond what they can access in the health center, but the nearest specialist is 6 hours away, or, even if it's 3 hours away, they don't have easy transportation. They can't take the time off of work. What does that look like if you eliminate that from the process? It's sort of like, okay, then they become probably sicker, or they just go on and then they end up in an emergency room. It's just sort of like, again, yes, okay, in person can be great. And Renee, I will only say this, I think that in the health center space, there are so many providers who have literally seen generations of patients where, they started seeing someone as a child and they're seeing their kids now. And so there is that personal and human connection. And I think for a lot of providers, that's why they stepped into the space. And so, as I said, I think there are some who really appreciate that in-person opportunity. But I think more than anything, at least in the health center world, I don't want to speak for anybody else, but I suspect it's similar. They got into this because they want to treat the needs and serve the needs of their patients. So if their patients can come in and make it in person and that's what they need, they'll do it. But if that doesn't work for them, we want to meet them where they are. But I would just call out even the specialty care component of this, because the reality is, what's better? Forcing someone to do something in person and having to wait potentially 6 months or more for them to do it is definitely the case of behavioral health. But for a lot of the specialty services, if telehealth wasn't an option, you'd be going far too long to get folks that connection to that access, which just worsens their condition.
But I get your point, Amanda, about the relationship. But my point is that relationships can still continue if part of it is virtual, right? And I think that was my point. And I think some of this mirrors the sort of back to work debates we're having. And I think when I hear these debates, sometimes it's one or the other. What I think we're all arriving at is it's a mix of both. It's flexibility. What works for one might not work for the other, right? Both from a clinician perspective and a consumer perspective. There are going to be some consumers who want to go in person if they can, and there are going to be others who say, look, if it's not necessary for this particular visit, this particular condition, I'd rather do this virtually. So I think that's where we are. I think we're in a transition phase where I think what's going to come out at the other end is much more flexibility in terms of how we do visits. The other thing I would add is I think the visit itself, and Anne, you talked a little bit about the consumer experience. I think the visit itself has to change, and we need to get to sort of what I would call 2.0 version of this, right? Where you're able, where part of the visit involves the measuring of all vitals. We can do this. There are organizations and companies out there that have built Bluetooth-enabled remote devices that can take blood pressure and everything else in real time. We need to have a way to get all the information we have from wearables into the visit, right? In some way. I know a lot of that data is not actionable and it's not particularly useful for clinicians as raw data, but I think that's where we need to go into sort of the next generation of telehealth visit that incorporates technology in a much more seamless way that's incredibly effective for both patient and clinician.
Got it. There have been a lot of questions, and I appreciate the discussion. Thank you all. There have been a lot of questions in the chat about reimbursement, and some get pretty specific with codes and so forth, and I don't think we're in a position to answer those today. But I do want to talk a little bit about reimbursement and sort of step back even further and look at the notion of how we evaluate our investments in digitally enabled care, technology-enabled services. So we have a tendency to look at it from an ROI perspective. And that makes my blood run cold, but curious what your experiences or thoughts are on how we evaluate it. And I ask because I think that if you are, and Ativ Malhotra, who's published extensively on telehealth and really has co-authored a number of studies and thought pieces on this, and very much a truth teller, if you will. He talks about the need to not look at cost per se. His point is that if you're going to increase access, you will increase cost in the short term. That's just a reality. And so we have to look at other measures or other metrics. And so what our disparities group looked at was this notion of economic and social value added, the value of a life that's healthy and long-lived, contributing to the community, supporting their family. Those are how we're countering it at the ATA, but curious how you all are looking at this notion of ROI, particularly in a fee-for-service environment. Alan, you want to take it?
Yeah, I really thought that we had gotten past this. I feel like I mean, you can just look at some of the work done by the Rural Policy Research Institute out of Iowa, looking at cost savings from transfers, utilizing telehealth, number one, huge cost savings. Published also research looking at electronic emergency room services and decreased costs on this. I feel like I could build an entire presentation of just slides with that data, and maybe I need to do that so we can get past that discussion on it. And on a similar note, one of the comments I said that I saw down below, it asked the question about any data on quality of care in rural America. I do have a presentation where I just go through 30 slides showing peer-reviewed quality data, CMS data showing that from primary care has as good, in many cases, better outcomes than urban providers. So that's on me. I mean, that's on us of not doing a good job of just driving home the data again and again, showing the cost savings of telehealth. But we shouldn't have to do that because you see a lot of insurers now including this service in, and that there's no better indication of the value and cost savings than insurers now including this as well too. Sorry, you really got me on a soapbox on this particular issue, but it's a hot button issue for me.
Got it. Amanda?
Yeah, I mean, I think Alan actually covered quite a few bases, and I'll just kind of echo and say that, you know, the outcomes are there. And I think part of it is just kind of documentation and proof and bringing it up and the advocacy behind it. So I think all of us need to do better with that. It is troubling that that's necessary. I will just call out though that, and I so appreciate what Renee was getting at in terms of, the need for the telehealth is so expansive. Obviously it's the visit, but then there's also remote patient monitoring and all of the devices that go along with it. I will just call out that it's difficult to get, whether it is policymakers or corporate or partners, it's difficult to make the case for investment to connect specifically underserved populations with some of those technologies, and they don't have the means to access them on their own. And so there's a little bit of a disconnect there around, okay, it's hard to create the proof and demonstrate the ROI if you can't get the technology to the people who actually stand to prove those efficiencies, prove those returns. And so it's a little bit of a circular, discussion, but I think end of the day, the proof is there, the data's there, the outcomes are there. I think health centers certainly can document that, especially through the experience the last few years. But I think it's going to take, more resources, and a lot of that comes down to advocacy.
Mm-hmm. Great.
The only thing, I agree with everything that's been said. The only thing that sort of troubles me is we've been having this conversation for the better part of 2 decades. And I think COVID advanced the ball a little bit. But when I look at what's being developed outside of the telehealth context, next-gen wearables, biosensing technology, AR, VR medical devices, digital therapeutics, AI-enabled solutions, all being developed at a rapid pace, all could potentially have high impact on the general health of the United States. And here we are, still talking about the viability of telehealth, the ROI of telehealth. If we can't get that right, and we can't get that straight, what chance did the next generation technology have? That's what's troubling me a little bit. The conservative nature of our healthcare system, the inability of the healthcare system writ large to really absorb and take on innovation. And you see it in other sectors, far ahead of healthcare, thinking banking. Think about banking in 2000, think about banking in 2023. Complete sea change.
Yeah. Well, I think part of the issue is that we're, this notion of scaling in healthcare, if we were rooted in bricks and mortar and much more of a cottage industry, very siloed, it's difficult. And again, if you think about mistrust about health generally, I think in many quarters among legislators and regulators, there's mistrust about scale, running things at scale. But Renee, you touched on something that was also a question in the chat. If you look at the next gen wearables and some of these other developments that are out there, many of them have AI under the hood. What role is AI in particular going to play in telehealth and in specifically access to care for the underserved communities?
That's a great question. I am not sure, to be honest with you. I think we're early stages yet, and I think the most effective AI solutions that we see today are, I would say, focus on administrative operational burdens. For the most part, although there are developments in other areas as well. But I think ultimately down the road, if I were to project, I would say AI is going to play an incredibly vital role in the US healthcare system. Whether or not it exacerbates what's occurring today vis-a-vis health disparities, I am not sure. But if all we do is take innovation and layer it on top of an already dysfunctional system, we're just going to get the same outcomes and results, maybe even worse. And that's what's troubling for me.
Got it. Amanda?
Yeah, I was going to say, I think it's definitely to be determined. I think it's still, I was actually just about a week ago engaging with a health center who is doing some work and piloting in this space. And so I know that, at least across our membership, across some number of health centers, they're looking at this and they're trying to build something to create efficiencies, to, improve the ability across the workforce, all of it. And then of course, all of it goes to outcomes. But I would agree that what Renee just said, that, if you layer something on top of a very broken, dysfunctional system, it isn't going to produce the changes that you want. And so I think whatever is to be has to be done in a way that really takes those issues into account. And so my hope is that as, health centers and others are looking at how to integrate AI into their systems, that'll be integrated with population health, that'll be integrated with cultural sensitivity, that'll be integrated with the importance of workforce diversity. It's just sort of like there's so many different components. It's not a plug and play. But it's also exciting because I think there is the potential to see incredible outcomes and incredible advances. And, it's just going to take time. But I will say technology moves quickly. So I hope that as quickly as it goes, we can also have some moments of pause to say, okay, is this actually making improvements in the way that we want and need? And then, continue to evolve from there.
Ellen?
Yeah, I would just say from a rural context, a lot of the discussion about the new technology, most notably wearables, it's about empowering patients to take care of their own care. And anytime we can give rural underserved communities tools to be able to take ownership and care of their own health, I think is great. I haven't seen a lot of research published yet in a rural context about AI integration into primary care. I've heard a lot of hallway conversations about it just this year about clinicians saying in passing how they're utilizing that in their practice. And that's offhand. I think this is right to what Amanda said. This is happening in real time. It's going to happen a lot faster than we expect it to.
Got it. We are coming to the close of our time. I think we have time for one more question. And I, of course, have the prerogative to flip through and see which ones I want to pick on at this point. But, I would love to hear a little bit more from each of you about how we join together to tackle this issue of underserved communities. This is a problem that we have not dealt with, but has been prevalent in the United States for literally decades. Dartmouth Atlas, as I've said many times, did a great job of demonstrating that. And the fact that we don't have evidence-based guidelines evenly distributed across the United States. So this is something that we can and should fix. And so I personally have a sense of urgency about this just because I'm not getting any younger. Parting thoughts from each of you on what we can do differently? Renee?
I'll start. I think we need to create a forum in which the various sectors of the healthcare ecosystem have the ability to talk, communicate with each other so we know what each other is doing, what the concerns are, because I don't think there's any coordinated sense of these sectors working collaboratively to solve some of these problems. They barely even talk to each other. So I'm thinking the tech community, the payer community, the health system community, the rural health community, the FQHC communities. There's no forum for these folks to talk, to change ideas and views. And so if we could create some kind of forum, doesn't have to be formal, it could be informal, I think it'd go a long way.
I know we're out of town, so I'm just going to agree with what Renee said.
Perfect.
Ditto, and thank you.
Yeah, thank you all so much. And I want to remind our audience that number one, if you've asked for resources or decks or studies that we've done, I'm sure we'll make it available to everyone. You need to log out of this session before you go to the next one, which is on broadband. And Commissioner Carr is moderating that. So to my panelists, thank you. It's always a delight to be with you. So thank you so much.
Thank you.